you, Taylor. And good afternoon, everyone. Before we begin, I would like to let everyone know that this session is being recorded, and these recordings will become available on our DentEcho website after session. And we are very happy to have everyone join us for the 30th Dental Education Network for Texas Echo, known as DentEcho. And this session is brought to you by the UT Health San Antonio School of Dentistry. I'm Kato, and I will assist in facilitating today's session, and Taylor will be our wonderful IT support for this session. Next slide, please. And here's a brief look at today's session. We'll start with some housekeeping and introductions, followed by a didactic presentation and case presentation from Dr. Kwan and Dr. Courtney. We'll wrap up with a Q&A session at the end, and so please save your questions for then, or feel free to use the chat throughout. Next slide, please. And some housekeeping items for the session today. These sessions are recorded and will be available later on the DentEcho website, along with the slides. And please stay muted unless you're speaking, and we encourage you to use the chat or the raise hand feature to share questions and perspectives. To help us track attendance, please enter your name and organization in the chat. And remember, no PHI or personal health information should be shared in the chat or during discussions. If you run into any connection issues, Taylor is available by chat to assist you. Next slide. Thank you. And for those who may be new to ECHO, this is a model that builds virtual communities of practice and learning. Sessions include a didactic presentation and de-identified case-based learning and group discussion to foster deep knowledge and build individual capacity. ECHO is an all-teach, all-learn supportive model, and ECHOs thrive on the interaction from the full learning network. So we encourage everyone to participate in the conversation today. Next slide. And today marks an exciting milestone for us. This is our first DentEcho session on the iEcho platform. And there are two important updates to highlight. In addition to the platform transition, our schedule has changed. Instead of meeting bi-monthly, we will now meet every third Thursday of the quarter from 12 to 1 p.m. Central Time. And we appreciate everyone's flexibility as we implement both the platform and schedule changes. And if you have any feedback as we move forward, please let us know. Next slide. And to receive CDE credits, please stay for the entire session. If you want to register for CDE, you can do so now using the link in the chat or by scanning the QR code. When registering, please use the super code ECHO 2026. And from the hub team today, I think we have Dr. Dar, I'm not sure if Dr. Marwaha, Dr. Rankar was able to join, and Vanessa. And Dr. Dar, if you can please introduce yourself, and then please also introduce the speakers for today's session as well. And Taylor, could you please go to the next slide?
Absolutely. Thank you so much.
Thank you.
I'm Dr. Shohini Dhar, Assistant Professor with the Department of Comprehensive Dentistry here at the School of Dentistry. It's my absolute pleasure to introduce Dr. Cohen and Dr. Porty for today's presentation. Thank you both for sharing your knowledge and time with us this afternoon. Dr. Tracy Cohen is a dedicated dental professional recognized for her clinical excellence, leadership, and commitment to dental education. She earned her DDS from our school, UT Health School of Dentistry, in 2017 with a distinction in dental education, was a participant in the prestigious Dental Early Acceptance Program, and is a Terry Scholar alumna. Since 2022, she has served as a full-time assistant professor, course director, leader in pre-doctoral clinical education. In addition to lecturing internationally on digital dentures, she has led innovations in digital denture workflow in private practice while mentoring dental professionals and fostering strong patient-centered teams. Welcome, Dr. Cohen. Dr. James Corte is a dentist and a public health professional who earned his DDS from West Virginia University in 1993 and completed his Masters of Public Health from University of North Carolina, Chapel Hill, and Dental Public Health Residency from University of Texas in Houston. He has held academic and leadership roles including serving as the founding dental director at the Community Health Centers of South Central Texas, and has worked extensively in diverse communities from Africa, Central America, the South Pacific, Native American Reservation, and the United States. In addition to his dental career, he is an entrepreneur and philanthropist who supports African women through the sale of shea butter and African black silk. He also founded the nonprofit Light a Village to provide solar energy to rural communities and leads um, Kingsworth Farms, an organic neem oil and fertilizer company. Thank you, Dr. Corte, for being with us. And thank you both. You have access to both Dr. Cohen and Dr. Corte's very illustrious career and bio sketch through the platform. I just tried my best to tell our audience about their career and educational background in a nutshell over here. Welcome, both of you, and looking forward to your presentation. Thank you.
Thank you.
Thank you so much, Dr. Dar and Dr. Cohen and Dr. V. Whenever you're ready, please take it away. That's good.
What are fractured and cracked teeth? How do we categorize them? And what do we even call them? The definition has changed quite a few times over the past years, leading to quite a bit of confusion and mismanagement within our profession. Over the last 72 years, the name cracked teeth have changed from the original cuspal fracture odontologia to more common terms such as crazed lines and cracked tooth syndrome, which has been around since the 60s. The figure published by Ellis in a British dental journal lists the various names that have been used from the 60s to the 80s. It is evident that the literature regarding cracked teeth involves conflicting points. Much like the names, most researchers established their treatment strategy based on personal preference rather than universally agreed protocols. Opinions in treatment and literature are almost as varied as the history of the names. As tooth cracks and fractures are frequently a source or lead to pulpal symptoms, I'm going to default to the current American Association of Endodontics definitions for cracks and fractures. Currently, the American Association of Endodontists define a cracked tooth as a thin surface disruption of enamel, dentin, and possibly cementum of unknown depth or extension. A tooth fracture is also defined as a disruption of dentin, enamel, cementum of unknown depth or extension, visible or not visible, clinically or radiographically, with separated or unseparated segments. However, a fracture is assumed to be of greater depth than a crack. A crazed line, or currently called an infarction, is a crack in the enamel without loss of tooth structure. Sorry, pardon me. And an abfraction is that V-shaped loss that we commonly see at the DEJ that is caused by flexure of the teeth. The American Association of Endodontics has also categorized all sorts of fractures. Traumatic fractures of the teeth with or without tooth structure loss are attributed to an acute trauma. Sports injuries, biting on something hard, these are broken down into whether or not they concern the pulp, whether or not there's tooth structure loss, and what part of the tooth is involved. They have other major category are root fractures. We have horizontal and longitudinal root fractures. I'll be spending most of my time discussing uncomplicated enamel dentin fractures. Remember, a fracture is of unknown depth, according to the Association of Endodontics. But remember, the American Association of Endodontics say a disruption of unknown depth or an extension This is where the confusion and lack of consensus across the dental profession. Despite their official definitions and categories and treatments, we still do not have a complete consensus on what to do with cracked and fractured teeth, especially those that are asymptomatic. Or their root fractures, right? We have longitudinal as well as horizontal root fractures. I'll talk a little bit about vertical root fractures as some information there is pertinent as well to your typical cracked or fractured tooth that doesn't have any loss of tooth structure. So what's bringing this subject up now? Our pre-doctoral clinic sees something in the realm of 300 patients a day, and I see cracked and fractured teeth in most of the patients of the students I work with. Whereas this is not brand new, even before COVID, this has been an increasing phenomenon, especially as our daily life stressors increase. In 2016, a survey of endodontists, it was found that 49% noticed an increase in cracked teeth. This was 10 years ago. According to Forbes magazine, 2016 was an okay year for the economy. Not bad, but not great. Still recovering, but weak. However, when COVID hit in 2020, this became a major time of stress for our population. Dentists and specialists noticed such an increase in cracked and fractured teeth that even the general public picked up on it. Even now, with one quick glance at the news, I don't imagine that our stressors environments are just going to go away. First, what causes a cracked or fractured tooth? I know this is a very busy slide. We have two main categories, dentist caused and non-dentist caused. I put all of this here for your information. However, I'm going to focus on the non-dentist caused factors on the right. We simply just don't have enough time to tackle all of these individually. We have in the non-dentist categories, we have factors such as aging, dental structure itself, with steep cusps and deep occlusal grooves, as well as repetitive trauma and mastication. One study noted that mastication accounts for 54% of fractured and cracked teeth. Now, who in this population does all this affect? Everyone. Don says with major medical conditions, most of all of our patients masticate, as you probably are doing right now since it's lunchtime. So the biggest cause of fractures is caused by an activity that almost every day, every patient does frequently. One study noted that fractures are seen equally across males and females, and generally are an issue from 30 to 60 years of age. This is about the time in our lives that we receive the most stresses in our lives, families, work, mortgages, and many more stresses are prominent during this time. 70% of patients have at least one posterior tooth with a visible crack. Our tendency towards developing cracks and fractures later in life start at development. A brief review, our teeth develop from the tip of the cusps on down. Teeth with multiple cusps have multiple points at which each tooth starts developing when we're babies. Each one of these points are called a lobe. In multi-cusp teeth, dentin formation begins independently at the sites of each future cusp tip, and again spreads down the cusp slopes until they fuse with the adjacent centers. Where these developmental lobes coalesce or join together form the grooves and fossa that we see on the tops of our teeth. Where these lobes join can be inherently weaker to lateral forces. If we look at the premolar, we see that the entire lingual cusp is one developmental lobe. And how many of us have seen premolars where the entire lingual cusp shears off? Our teeth are not solid structures. They are full of tubes called dentinal tubules, which allows for certain permeability, which is why when we get cuspal responses to outside factors. These are tapered structures that are larger near the center, near the nerve of the tooth, and they're thinnest on the outside where the dentin or the inner soft part of the teeth meets with the white outer layer we look at when we see in the mirror. These tubules aren't always just straight. They can branch, with major branches occurring more frequently in our root dentin as opposed to dentin towards the coronal portion of the tooth. Despite developmental formations, a tooth does inherently have resistance to fracture. This is called fracture toughness and is the stress inherently required to cause a crack to propagate rapidly without limit and ultimately becoming catastrophic for the tooth. This fracture resistance of human dentin is not the same all the way through and exhibits location-dependent variations. Dentin is also a lot more resistant, it takes a lot more force to crack propagation than does enamel for the outer part of the tooth. One reason for this difference in fracture resistance is related to the collagen fibers that are available in dentin. Collagen fibers have a random orientation in coronal dentin, whereas in more radicular or root dentin, the collagen fibers are oriented in a more vertical crown to root parallel orientation. As I mentioned before, major branches of tubules occur more frequently in the root as they do the crown. Another thing to note is that the megapascals of force required for crack propagation changes throughout life, as we do. The fracture toughness of dentin decreases with age, making older teeth more likely to fracture. This is associated with a loss of elasticity in the collagen fibers as we age. Other inherent defense mechanisms to help slow progression of the crack and fractures. When a crack starts, the structure of dentin actually increases in toughness in response to that crack. Energy dissipation occurs as collagen fibers slide past one another, which is why elasticity of these are so important. This elasticity creates plastic zones that deform at a tip of a fracture that help to blunt and slow the tip of that fracture. Crack bridging, it occurs as ligaments connect the crack faces of different lines of fractures, right? Fractures aren't always just one singular fracture coming down through the dentin. This decreases the inherent stress and increases the amount of force needed for this crack to propagate. Crack bridging actually accounts for the major protective factor and 26% of the force required for a crack to grow in a tooth. One other defense mechanism is crack deflection and branching. Right, this is caused when a crack runs into a dentinal tubule, as you can see in the second picture below. When this happens, the crack fans out, and this serves to disperse forces over a larger area. Considering the different mechanisms available for dentin toughening, one is compelled to ask, why do we still have all of these fractures so frequently in teeth? And this is a multifactorial problem that is very difficult to identify as one singular root cause. However, the most direct answer is that fracture toughness values of dentin relative to other materials that we're familiar with are low. These values are at least 10 times lower than the fracture resistance toughness of most engineering materials. More importantly, the initiation toughness of dentin is very low. This allows cracks to initiate from incipient damage and trauma in the tooth under low stress, even such as when we bite on a seed or a bone chip. It doesn't take much. It takes far less force to start a crack than it does to propagate it. We bite on a seed and then continue to put our teeth through cyclic stresses, such as mastication. The cyclic loading overworks plastic zones, causing the tooth structure to become more brittle. As the tooth structure becomes more brittle, this decreases the amount of force required for propagation of a crack. As I mentioned before, aging also decreases the effectiveness of these defense mechanisms. This degradation appears to be a result from changes in the microstructure of the dentin itself, its chemical composition, as well as increase cross-linking between these collagen fibers. The more they cross-link, this decreases plasticity, or the ability to deform without breaking. As the ability of these collagen fibers to slide past another decreases, it causes more brittle tooth structure. However, aging and cyclic forces are only part of the reason that our dentin's natural defense mechanisms eventually get overwhelmed. Bacteria, like most of the problems in the oral cavity, bacteria are the other issue. Most of our most common tooth-related issues really are driven by engineering and bacterial issues. Bacterial invasion into the crack helps to further the degradation of our defense mechanisms. Cracks are not just open air spaces in teeth, but however are filled with bacteria and bacterial biofilms. The presence of this bacteria and bacterial byproducts in the crack help to further degrade the surrounding collagen and weaken the tooth structure. This is allowing faster crack propagation, as well as accounts for some of the symptoms that present when a person has a cracked tooth. Symptomatic fractured teeth are like electrical issues in cars, for those of you that are car people. Symptoms can be inconsistent, hard to find, and hard to replicate. Often those symptoms mimic other disorders in teeth. Along with the physical separation of the cracked pieces and the fluid movement in the tubules, this causes the presence of bacteria and bacterial byproducts, causes inflammation. The pulp tissue response varies according to the location, the direction, and the extent of the crack. Remember that dentinal tubules are tapered structures and that are larger near the pulp and thinnest towards the outside of the tooth. However, the dentinal tubule diameter is usually compatible with the cell diameter of most oral bacterial species. Dense bacterial colonization of cracked dentin permits bacterial virulence factors and antigens to concentrate and diffuse into tubular fluid to reach the pulp in levels that may be sufficient to cause this inflammation. Bacterial byproducts also present in the dentinal fluid and reach the pulp long before the bacteria themselves actually do. The intensity of inflammation in several studies was directly proportional to the depth of bacterial invasion in the tubules. However, it has been postulated that the intensity of the pulp response to dentin infection depends not only on the proximity of bacterial infection to the pulp, but also on the concentration and relative virulence of the bacterial products themselves and the area of dentin involved. Remember, some of these cracks start to fan out and fissure and take over a larger area. So one could postulate that the larger the crack, the more branching, the quicker the bacterial byproducts will get close to the pulp, causing a larger response. Besides our classic pulpal symptoms of spontaneous pain to biting and sensitivity to thermal stimulus, other symptoms can be present that are percussion sensitivity, sinus tracts, swelling, oral facial pain, mobility, increased probing depths. However, cracked teeth can also present with absolutely none of these. We do have various diagnostic aids at our disposal as practitioners. Cannot tell you how many times I've heard, Dr. Cowan, please, I do not see anything wrong clinically and there's nothing on the radiograph, from dental students when a patient is suffering from a cracked or fractured tooth. I myself at one point was one of those students. We can conduct electronic pulp tests to evaluate pulpal vitality. We can use a tooth sleuth, use a fiber light, dye the tooth, perioprobe, evaluate radiographs, and even remove an existing restoration to then use any of the previously mentioned to help in diagnosing cracked and fractured teeth. Loupes are common in dentistry. However, some literature reports that 16 times magnification is optimal for the diagnosis of cracks and fractures. Something interesting is not only is there not a general consensus in literature on how to treat cracked teeth, there's also variations across the dental specialties on how cracked teeth are diagnosed. and which of the mentioned methods are used. A survey of general dentists, prosthodontists, and endodontists conducted in 2021 showed that endodontists and prosthodontists were more likely to use transillumination and restoration removal than general practitioners. 87% of the endodontists compared to 47% of the prosthodontists and 31% of the general practitioners used magnification. There was also interesting data reported in this survey and discussed about general age of those that were involved in the survey, length of time of being a practitioner, with the GPs being overall a younger group with less years in dentistry than our specialist counterparts. The amount of referrals from GPs tended to decrease as GPs increased in age. One could postulate that the more interaction earlier on between these groups concerning continuing education could really help in treating our patients. For our tooth sleuth, what we're doing is we're using this bite stick to evenly isolate and apply pressure to individual cusps on teeth. A downside to this is that if a tooth has symptomatic apical periodontitis, the tooth is going to respond positively regardless of where you have them bite down and which cusp you're isolating. The cupped side is used for the cusp, as well as the flat side is used against the opposing tooth. We want to apply pressure slowly and evenly until the full bite pressure is achieved. This can be difficult in some patients who have been having a lot of pain with their cracked teeth because they just don't want to bite down because they know it's going to hurt. The patient is then asked to quickly release. Commonly, this cracked tooth is going to elicit pain with the quick release of the biting pressure. Everyone's going to always be a little biased, and I'll be honest, this is my favorite method. This is the most common modality for fracture diagnosis used by endodontists, is transillumination. It is the use of a bright fiber optic light that we place directly on the tooth surface. Teeth with crack extending into dentin will block that transilluminated light. With the part proximal to the light will transmit and glow, and the area beyond the fracture will not transmit this light and be dark in comparison. If the crack does not extend into dentin, then the light will still transilluminate, right? So this is how we can differentiate our crazed lines from our more deeply fractured teeth. It's also helpful if you test from multiple locations on the tooth. Don't just place the tip of the light in one area. I've always found this is hard to get a picture of in the clinic, but I do have this lamp at home that I absolutely love that shows the decrease in light transillumination above the crack. And I did take this thing apart and look. That crack goes all the way through, courtesy of my cats who dropped it one day. Not every practice is going to be equipped with every piece of technology. But in my time traveling as the Saturday guy, traveling to various practices, I found it was always handy to have my own transilluminator. In a pinch, I've used the light on a high-speed handpiece without a burr in it when there was nothing else. No one pays me for this, but for those of you that really, really don't want to spend a lot on this, there is a Bohr light on Amazon that does the same thing that our transilluminators do. It's also really hardy for traveling. Some drawbacks here, though, is that for an unfamiliar provider, crazed lines can appear as structural cracks, which is why it's important to use multiple points of reference when looking for cracked teeth with the transilluminator. Subtle color changes in the tooth are also rendered a bit invisible when the tooth is lit up. And the biggest one is restorations block the light and may need to be removed for a full diagnosis, even though you're using a transilluminator, especially if this is a patient that's traveled from dentist to dentist and you didn't place the restoration yourself. Staining is another method that we can use. The methylene blue dye. This is applied to the tooth and the excess is rinsed away. Once again, may have to remove this restoration to fully see the extent of crack. And we can remove the dye with 70% isopropyl alcohol. However, maybe don't use this in the aesthetic zone for your patients. Plaque does stain profusely, and when we decalcify enamel and dentin, the dye is going to absorb into the structure itself. If you're performing a root canal and you're using the hypochlorite, prolonged exposure to sodium hypochlorite can cause the absorption of the dye by making the tooth structure itself more porous. Once again, the same thing with the small subtle color changes deeper in the enamel really are rendered one color. And over-reliance on dyes may handicap a clinician's ability in the end to routinely discover earlier cracks. Radiographic interpretation in a periapical film. This can be useful for our vertical root fractures and horizontal root fractures. However, not all fractures can be seen on this type of film, right? We can see vertical root fractures only by the pattern of the J-shaped bone loss around the tooth itself. However, not all cracks have been there long enough for that inflammation response to take part and cause this. Sometimes we just have to listen to our patients as opposed to using the x-ray, because the x-ray just won't pick it up because the bone has not had enough time to resorb. Visualization of these cracks is also really dependent on the angle of the beam of x-rays in relation to the crack. Right? We can generally see some of those buccal lingual, but we cannot see those mesial distal cracks in teeth on periapical films. For CBCTs, it's beneficial to use a small field of view with high resolution. Root fractures are generally curved or irregular. They don't generally appear straight or uniform. When you're looking at your axial slices of your CBCT, they'll look like irregular lines. These lines will also be present in several slices. You want to make sure to look into 3 or 4 slices at least and scroll through. This will help you differentiate a fracture from noise and artifacting in the CBCT. Noise and artifacting can be especially prominent in root canal treated teeth or teeth that have a lot of dense metal. Bone resorption is going to be present at the site of the fracture, and it generally is going to be pretty even around the fracture, with the fracture being more towards the center of this. Bone resorption can be useful even if the noise is preventing us from actually seeing the fracture itself. However, fractures can be confused with anatomical radicular grooves, right? Especially common in premolars. These show as long straight lines and can even be associated with bone loss as the bacteria travels down that groove. A distinguishing feature of a radicular groove is that the edges are rounded as it exits the tooth, as opposed to being very straight, as seen in the fracture. Fractures can be confused with accessory canals. However, if we manipulate our CBCT, we can differentiate these. If we parallel the proposed accessory canal to be parallel and perpendicular with our with our navigation lines, you'll typically get a line dot pattern where in two of the views you're going to see a line as seen as B and D, and then the third you're going to see the dot, right? This is indicative of an accessory canal, and it's not how a fracture will appear on CBCT. Accessory canals are also a little bit more straight as well. I'm going to take a moment to talk about risk of propagation. There was a paper published by Drs. Clark, Sheets, and Paquette in the Journal of Aesthetic Restorative Dentistry in 2003 that attempted to categorize risks of fracture by propagation. And so they put crazed lines only in enamel here, vertical, uniform, they don't widen, penetrate around restoration, without restorations and without any stain. These are really low risk of propagation and generally do not need treatment. Your moderate risk is when you start seeing this wedge shape or this V-shaped ditching as a result of enamel tooth structure loss within the enamel itself around the crack. Right, this is when you can start getting the tip of your probe into that crack, and these are going to have moderate risk of propagation. Your high risk of propagations are going to be your diagonal cracks that branch off from vertical cracks. These can be indicative of late stage oblique incomplete fractures. Horizontal or diagonal cracks that normally emanate from a corner of a restoration. These will narrow as they extend gingivally and are typically nonlinear. These cracks house debris with or without previous restorations, indicative of a crack. Pairs of cracks that outline an area as well, right? Cusps, marginal ridges, discolored enamel, right? This is where translumination becomes a problem because we can't check the color of the enamel around some of these restorations and around the underlying dentinal crack. Cracks that have corresponding halos, brown, gray, white, that are centered on these. These are going to be your higher risk for propagation. And so here's some photo of a few of those. You can see some of the diagonal cracks, the vertical ones branching from a more vertical crack, the ones emanating from the corner of restorations. If you ever see the marginal ridge crack as well as a fracture in the enamel itself, right? This one is highly indicative of this crack progressing more towards the floor of the pulp. And so you're going to talk to your patients and they're going to ask, do I need a crown? Do I need a root canal? What do I do? What do you think I should do? And there's a study that was completed over 25 years that included data from 2,086 patients. It's called the Iowa State, and they created the Iowa Staging Index. Within the study itself, it talks about success versus survival, where success is defined as a resolution of previous radiographic pathosis and the absence of any signs or symptoms. This is more of a clinician-centered terminology and is more strict than survival, which is become more frequently used as more of a patient-centered term. Survival meaning the tooth is present, asymptomatic, and functional, but it can still have signs of apical pathosis, either radiographically or clinically. Some older studies called these tooth to be questionable. And survival statistics are always better than success statistics when you're reading in literature. The three factors that were found to be most effective of determining whether a case was going to be successful in treating a cracked tooth case, and all of this teeth in this study were treated with a root canal and a crown. But these three factors were the probing depth, the location to the crack, and the periapical pathosis. The stage 1, 2, and 3 with the best success have a less than 5 millimeter probing. Stage 4 is really where we start seeing a huge decrease in those successes at 41%. With stage 1 being, less than 5 millimeter probing. The tooth only has a mesial marginal ridge crack. There's no distal marginal ridge. There's no apical pathosis. In these teeth, a root canal and crown success rate was 93. The survival rate itself was 97.
I'm so sorry, Dr. Cohen, to jump in to make sure we have time for cases. If you can summarize.
Yeah, I can do that. Stage 2, you're different here is it's going to have a distal marginal ridge fracture as opposed to a mesial. In stage 3, these had a distal and marginal ridge crack as well as a diagnosis with apical pathosis. Stage 5, like I said, these were the ones, or stage 4, these were the ones that had a greater than 5 millimeter probing depth anywhere near the fracture. So treatment, it's the part that everyone's been waiting for. It's the magic crystal that's going to solve this massive and varied problem. And as a reminder, there is no consensus concerning the treatment of these in literature. And even the American Association of Endodontics describes a crack and a fracture of unknown depth or extension, and they assume. I do want to amend this statement slightly. There's some consensus concerning the treatment of cracks and fractures. The American Association of Endodontics states, not all cracked teeth require root canal treatment, but all cracked teeth require a crown. The earlier these cracks are diagnosed, the better the survival rate, okay, of doing a crown. 2 studies showed that 79% of teeth with reversible pulpitis were crowned immediately, did not need root canal treatment. However, careful discussion is always going to be necessary with your patient, because up to 21% of the cracked teeth diagnosed with reversible pulpitis eventually do require a root canal treatment. And we've all heard from our patients, it didn't hurt until you put a crown on it. Improving outcomes of overall treatment is to immediately remove occlusal forces. Removing these repetitive occlusal forces are going to help stop the propagation of the crack, as they're one of the major reasons of that crack propagation, as we discussed earlier. And we can always encourage our patient to chew on the other side, but we've all forgotten to do that ourselves, right? Long-term protective measures against cracking and fracturing teeth would be restoring our canine occlusion and excursive when a patient bites, instead of having all the forces be on those premolars, but putting it back on the canine where it's supposed to be, with either orthodontics or full mouth restorative treatments. We also want to check to make sure that the maxillary palatal cusp is not creating a wedging effect on the mandibular molars. What about bonding? This is where literature really started to diverge. And they say a narrative review, because they were unable to do a meta-analysis, said that there was a high success rate with pulpal and tooth survival rates with the provision of direct or indirect composite restorations. Another one said that they had early detection of cracks. 85% of the teeth that were treated with composite were successful versus 100% in the cuspal coverage. Another study found that 50% symptomatic of cracked teeth were still symptomatic at 6 months. A 7-year study that looked at this found an annual failure rate of 6%. And this one's interesting because they looked at their data a couple of different ways, where it could say, yes, it was successful in that the pulp was healthy. However, due to the annual failure rate, that composites weren't a good fit. And then this last one, in a lab, direct and indirect resin restorations showed lower stresses on the restoration bottom. However, high stresses on the proximal end and the lower margin of the crack surface, thinking about that crack tip that was propagating, right? So increasing stresses there as opposed to decreasing. With a crown, stresses were concentrated where the crown bottom was. However, when they had a direct resin filling inside of a crown, these yielded significantly decreased stresses on both sides. I'm going to take just a moment to look at vertical root fractures. I know we're running out of time. Typically for vertical root fractures, everybody wants to extract these. However, there are options, right? For those that can't afford implants, historically, we've done hemisections and root canal treatment with crowns and had typically a very good survival rate. Once again, this can be an option for people who cannot or do not desire implants. Now, this is the reason I wanted to talk about vertical root fractures. For improving outcomes, there is there was a study that was done that found that when they put orifice barriers that went below the level of the crack, that they saw a 97% survival rate at 4 years of follow-up in these teeth. So they did root canal treatment on teeth with these vertical root fractures, but they did not bring the gutta percha all the way up, right? We put this orifice barrier, which is interesting to me because we talked about like a tooth's natural defense mechanisms of crack bridging, and bonding and decreasing stresses. This makes sense from a mechanical perspective. Just a few final thoughts, right? Cracks and fractures are considered to have unknown depth. They are formed and propagate quicker over time with repetitive forces. The closer to the pulp we get, the larger the tubules, the faster the bacteria and their byproducts are going to travel. We do not have, unfortunately, a magic crystal telling us when and for which patient a crack will propagate catastrophically. We do know that the earlier we diagnose and treat with a full coverage crown, the higher success rate for long-term preservation in teeth that are symptomatic. Remember our limitations on our materials if you're thinking about bonding and crown margins. We can only go so far subgingival or down the root structure and still have that bonding be effective. Some studies did show that asymptomatic teeth with cracks and fractures that were watched or bonded lasted for quite some time. However, some of these studies I noticed they didn't really talk about the patients or the presence of occlusal forces and whether or not they were bruxers, what their posterior guidance was in excursive, and where all those lateral forces were going. If a root canal treatment is required, let's use an orifice barrier to help increase the success rate. And once again, we need to evaluate and adjust that occlusion to make sure that we're reducing those lateral forces. Communicate with your patients because 21% of those cracked teeth with that reversible pulpitis are going to end up needing that crown and that root canal anyway. Okay. We all have our own personal ethical conundrum when it comes to cracked teeth, which is why there's no consensus. But given the volatility of cracks and fractures, by watching, at what point are we gambling on these cracks and fractures not progressing catastrophically when we know that what the definitions are, that we do not know the depth or extent, nor can we predict the time direction of progression? At what point are we waiting for the tooth defenses to fail and end up needing more invasive measures than only a crown? Each practitioner really has to take this whole patient's situation into account and rely on multiple points of evidence during an exam to evaluate a patient's risk of crack propagation and provide ethical, well-informed treatment. So I'm going to let Dr. Quarterly take over with case presentations.
Thank you. I'll try and keep this brief so we'll have time for questions and answers. First slide, please. So we're going to be talking about 5 cases, but what I would like you to take home is with the cracked teeth, listen to the patient, look at the symptoms, and if you decide to do a crown, like the doctor said, Dr. Cohen said, always remind the patient that there's a possibility of needing a root canal later on. So in my case, I usually tell the patient, if you can, if it's a posterior tooth, put a gold crown. It may not look nice, but it's back there, nobody's gonna see it. And if they ever have to do a root canal, it's easier to drill through a gold crown and do the root canal. So if you can, do that. So this was a relatively simple case when it comes to cracked teeth. Patient is 71 years old. She came in and she just wanted a comprehensive exam because she said at the top right side, the tooth was a little sensitive and it had a very bad smell. So she wanted us to take a look at it. So we took an x-ray and Number one, you can see the bone loss just around that tooth. That's the first sign of a cracked tooth most of the time. And for it to get to this stage, it means the tooth has been cracked for years, at least 1 year or more. And when we took the intraoral picture, you could see the tooth was cracked. And so we brought her back 2 days later and extracted the tooth, and the crack is all the way to the furcation. And sometimes when a tooth is cracked, the pain level is really low. It's probably about a 4 or 3. So it's not always that the pain is severe. So you need to be aware of that too. Next slide. This is another case where we dentists tend to say, oh, we'll watch it. So this case, the lady came in, was having pain on the lower right side. We adjusted the tooth because we couldn't see anything wrong with the filling or the tooth. There was no bone loss, nothing. So we adjusted the tooth and she still was in pain. So we took out the old amalgam and bonded it, put composite there, hoping that would help. But actually, I did this case, and I admit that was a mistake, because if you look at the marginal ridge, on the distal marginal ridge, it looks like the fracture has gone through the ridge. So at this point, we should have just sent her for a crown instead of even bonding it. That's my opinion. So we did bond it, put some composite over there, and I think about 2 weeks later, she came back that she couldn't bear the pain. She was still having pain in the area. So I reminded her that, remember we took a picture and I showed her the picture that in this case, she either has to go do the crown and root canal or extract the tooth. And she opted for an extraction. So we did extract that tooth. Next slide. This is an interesting case because this patient came in complaining of pain in tooth number 15. So my assistant got an x-ray of only number 15, and I looked at it, and 15 is the one that's x-ray on your lower right. It was obvious number 15 it looked to me like a cracked tooth. Or it could also be perio. But then when I went to see the patient, when I looked in the patient's mouth, number 12 was cracked completely. I mean, like split. But the patient said, no, number 12 doesn't bother him at all. There's no pain from number 12. Number 15 was bothering him. So I showed him in the mirror that number 12 was also cracked, and that if it was going to come back for extraction of number 15, we might as well do 12 and 15 on the same day. And the patient will not extract number 12. He said it's not bothering him, so he won't extract it. He just wants number 15 done. In this case, it's very important that you have the documentation that the patient refused treatment. Because anybody who sees this is going to wonder, why would you extract 15 and not 12 when they are right next to each other in the same quadrant? And 12 is obviously fractured. So make sure in a case like this, you have the patient sign a form that says the patient refused treatment. So This was just last week, so the patient is coming in very soon to have the tooth extracted. And we're going to do 15 and leave number 12 so the patient is ready for an extraction. But again, if you look at the bone loss pattern, it's not perio all around, it's just around the tooth that looks like it's right. This could possibly be perio or it could be a fracture. Next slide, please. This is an ongoing case. The patient came in complaining of pain in the lower right area, and we couldn't identify whether it was number 30 or number 31. There were tiny cavities on 30 and 31, so both were restored. 6 months later, the patient came in for a periodic exam and was complaining of pain, but this time she could isolate the pain to number 30. So we took it out of occlusion, adjusted it, and she felt like it was okay for a while. And 6 months later, which is like now a year, she came back complaining of pain from the same tooth, number 30. At this point, what would you do if you're the dentist? So what we've decided to do is to send the patient to an endodontist for reevaluation, a CBCT scan, and if it's fractured, then they can decide if it's a tooth that is worth saving, do a root canal and a crown. If they cannot do a root canal because the fracture is in some kind of manner that has gone through the root, then the best option would be an extraction. Next slide. And this patient, number 30 was missing, and number 31 actually had a very nice filling in there, but the patient was complaining of pain from that area, 31, 32. So we adjusted the bite, and everything was fine for over a year. And then the patient came back complaining of pain from number 31. And this time, you could see that from the x-ray that it was bone loss around 31. But the pain level was just a 3. So we figured maybe we could have them go to an endodontist and do a root canal and a crown. So we send them for a CBCT scan, and the endodontist said no, the fracture was through the root. They couldn't do a root canal. And so that tooth had to be extracted. So like Dr. Cohen said, if you suspect a fracture, the earlier you treat it with a crown, the better. And you could put any crown, ceramic crown, a gold crown, a porcelain fused to metal crown. My preference is posterior gold crown, anterior ceramic crown, just because it's easier if in future you have to do a root canal through the crown. But if you do the root canal before the crown, then it doesn't matter. Thank you.
Thank you so much, Dr.
Questions, please?
Yes. If you have any questions, please feel free to unmute, let us know, or type it in the chat. Thank you so much for the great presentation, Dr. Cohen, and also the examples and cases, Dr. Cohen.
Are there any questions or comments? Feel free to ask.
I have a question, doctor, please.
Go ahead.
what is your opinion on treating cracks with onlay Emax with cuspal coverage to preserve the enamel? So instead of just doing a full coverage with the crown, you just do a cuspal coverage with the Emax only and bond it to the tooth.
Dr. Cohen, you want to answer that? Because I don't have any experience with that, just I'm only.
Some of the studies showed they were a little back and forth on those two. That they definitely had a higher success rate and more consistency than bonding did. However, there were just slightly more failure rates there from what I could read with literature. But once again, it just depends on which ones you're looking at, because some of them said that they were just fine and could probably be a viable as well. However, for the symptomatic tooth, I'm going to default to the American Association of Endodontics stance on this, that crowns are going to be your most predictable way to care.
I know we're already at one, but there's one more question in the chat. If everyone can stay. How valid is to proceed with minimally invasive procedures as biometric approach, binding restorations with dentinol sealing and resin coating?
This is where I wish I had had more time to speak, because this is where it got interesting with, and why I introduced vertical root fractures at all, was with the binding and bonding the restorations, right? Seem to do a similar approach as the crack bridging in natural dentin on its own. And so that's at least my thoughts on why there were higher successes there. And internally, and once again, that kind of works with that other study too, that showed that internal bonding with the crown had a 97% success rate. However, something to keep in mind is the extent of the fracture, of where we can see that it goes, and the limitations of our materials, right? Many composites, certain crowns, they just don't do well on root structure or too far subgingivally. So sticking with our protocols that we know for our materials that worked best is going to give you the most predictable result at this time. We do, however, just need more studies comparing some of the more current bonding and current restoration materials with cracked teeth.
Thank you so much. Thank you for everybody for joining us for the 30th Dent Echo. Please complete the post-session survey in the chat. And we hope to see you in May. And thank you everyone for sticking around over time.
Thank you, everyone. Excellent presentation.
Thank you.